Here's another thyroglossal duct cyst. This one's a little bit harder to see how it's well circumscribed, but you can still get a sense of from where its location is. You would know. What do you think this is? Any thoughts? Something that's a little bit more rare.
Is it being in a muscle? Is it in a muscle or not?
No, not a dermoid.
Is it not in the stomach or your muscle?
I think this one was around, kind of around the neck area, but I can't tell you exactly where this was. Yeah, this is a lymphatic malformation. So there are malformations of the lymphatic system. You can see them in the neck, around the face. We've seen a few there. We've seen some on the chest, other locations. But again, it just gives you a sense of like some of the oddities you may see. Now, this is a fibromatosis coli, and we talked about it earlier. When would you expect to see it? What would be the clinical context?
Neonate.
Neonate with what?
Traumatic delivery.
And what would the physical exam be like?
Like a firm mass.
Right, firm mass. And typically, people were very comfortable diagnosing these without ultrasound. But if you wanted an extra level of safety, you can certainly look and see what it looks like. And you can see that structure there. It just kind of looks a little bit swollen, maybe. Okay. Here's another just cool lymphatic malformation. I thought I'd throw in a little bit of sequence, but you can see, almost get that snow falling appearance of the lymph tissue kind of swirling around. And then what do you think this is, just as a final image? What does this look like?
Cyst.
What kind of cyst?
Or in the midline?
So again, where you're scanning, this is hematoculpus. So it's important to know where you are because a lot of these cystic structures can look the same. And so again, this is just to remind everybody that the context and where you are is important. Appearances can be tricky.
Phase array.
So let's have a bit of a discussion. So after having gone through these very kind of classic scenarios, what's the role of POCUS in examining that mass? What do you think?
Identifying the structure.
Mm-hmm. Identifying the structure.
And then making sure that identifying if there is any infection or not. And then if there is, what type of infection, if it's an abscess, and we need to do an IND or not.
So structure. So when we think about lymph node structure and if there's an abscess or not, where it is in that spectrum? If it's any of the salivary glands, and we're looking for if there's signs of infection, inflammation, and if there's a mass or an abscess, excuse me, or if there's a stone. And then with some of the other ones, we're just kind of identifying what they are. So then it asks, what are the indications for comprehensive ultrasound?
That's a tricky and tough question.
Well, that's...
I know. I think it depends on a few factors. First of all, how well do you trust yourself and what you are seeing? That's one thing. Where exactly do you work? Like do you send all your patients no matter what for comprehensive, or
so your experience, your expertise, your setting can dictate how much scope you have. Okay.
And also I think the diagnosis. I think if it smells like lymphadenitis, you think it's a lymphadenitis, you put your probe, it looks like a lymphadenitis. So it's probably lymphadenitis, and I would send him home. If it looks a little bit odd to me, and maybe it can be a malignancy, so then I think I would still want to send the child to do a comprehensive one to make sure I'm not missing a bad thing.
So I can just share with you kind of my practice. So I feel pretty comfortable looking at lymph nodes, saying where they are on the spectrum. I think what I've taken away in preparing this is probably what I don't do enough of, is saying, I think this is an infected lymph node. I'm going to do a trial of antibiotics, said maybe have the child come back, but there's still a risk of malignancy. I don't think I write that probably like I should. I think in looking, I'm pretty comfortable looking at parotitis, making sure the ducts look okay and there's no abscess. But after that, I have to be honest, like things get a little wishy-washy for me. I'm okay if I find a brachial cleft cyst. I think I know what a thyroglossal duct cyst is if they're infected. I don't know if that's kind of the next place we should go now that we can kind of share images with everyone else over PACS. For us, we could take that image, refer to ENT, and they could look at them. With things like lymphatic malformation, I'm still going to make sure that gets a comprehensive. Anything that smells like malignancy for me in context is going to get a comprehensive, because I just think it needs to have a systematic evaluation that's beyond really the scope of what I do. But that's kind of my take home for neck masses. Any other kind of thoughts there?
Yeah, I think that's the crux of the next work maybe Nir and I will do is, you want to have an exam if you're going to be using clinical ultrasound that helps you change management, that helps you improve the patient's flow, whether that's by getting rid of unnecessary resource utilization in low-risk patients where you just want to reassure yourselves. And that's a pretty easy thing to sort of do, to say, if you were going to send every neck mass for an ultrasound and blood work and all these tests, well, how many of those testing cycles can you get rid of if you have, and if you can provide your emergency department with the reassurance of a low-risk POCUS? Then, I will say that the more I get lymphatic malformations, infected brachial cleft cysts, and abscess nodes that I scan, and I say, well, these are the higher risk ones. These are the ones I need to get a comprehensive scan for. All of those kids end up having pretty simple decisions. They either look well enough clinically to go home on oral clinic, or clinically they've had a more worrisome course. They've failed outpatient, they're highly febrile and not ranging their neck well. I'm not sure that there's an ultrasound feature that then distinguishes those. And I begin to wonder, when all of the cases get the same treatment, about whether what's the value in activating everything. But you do have that patient captured in a healthcare setting where you can get a comprehensive test. There are often patients that are going to get follow-up. So right now I haven't yet gotten to the part where I avoid consuming tests for the high-risk patients.
All right. So the objectives today were to recognize the advantages of POCUS for use in the assessment of neck masses, to demonstrate several common diagnoses to improve your decision-making in the emergent setting. Hopefully we've achieved that. I want to say thanks to the live studio audience. Thanks to the hundreds of people that are watching at home live, and to those that will watch later on in the recorded. I want to, say a special note how great that logo looks. It's great to have it back again.
We apologize for anyone with a seizure condition that is watching right now.
And of course, I'm on Twitter. If there are questions or concerns, commentary, discussion to be had. All right. Thanks. That's Neck Masses.